great to be here and see all of you this morning. And what Felipe was referencing was, until recently, I was leading analytics and research informatics in School of Medicine and Emory Healthcare, and now I'm working with the CDC and DHQP, working on innovation and surveillance and informatics needs for the division. But great to talk to you today, because this is some work that we started and has continued over at Emory in our IS team and our clinical care team. So I want to give you a little bit of our experience and then talk through some of the considerations from sort of an executive position when we're talking about turning on this capability. And when I think of this, I do think in a broader sense of subjective patient data as well as device data. Obviously, there's particulars for the different data types, but we needed to think through all of these types of data and how would we enable this. So I'm going to kind of go through some of our thoughts. So just the overview, and I use this slide in a lot of venues when we're talking about data from an academic medical center perspective. We've got sort of this whole ecosystem, and it's bigger than this, of data. And I made this slide months ago before I was planning on giving this talk, and I put patient-generated data in this complexity bucket, partly just because of the challenges that we were having in figuring out how to manage as a health system. And we've gone through a lot of that and talked through some of the issues around the workflow, but the data itself, especially if you're talking about turning on subjective patient information in particular, can be a bit messy. I think device data will be a little cleaner. So today I'm going to go through a little bit of the pilot project that Emory did in a partnership with Cerner and Apple HealthKit. Talk about a few of the key considerations around patient consent, how a health system considers who to partner with. Some of the, just a few, honestly, of the considerations we had during the build. And a very small mention of analytics, which could be, I think, a whole session in and of itself. And then I'll talk about the workflow a little bit. So this is a Cerner slide. I've got a few that I have permission to share, but Cerner is certainly, and Emory uses Cerner for their EMR, and for our portal we use Cerner. And so when we were looking at beginning a pilot, Cerner was looking for partners, and we were one of the first sites that did this health kit partnership with Cerner, and this was around glucometer data. And we had lots of lessons learned from this, which we'll probably be writing up and describing in more detail. But the idea, at least from the device perspective for medical care, is, some things fall into sort of the prescribed device category where your provider wants you on a wellness program. So from a fitness perspective, it is, an activity monitor, and I need you to hit these goals, and I want, and this is important, I want the information to come back to me at these intervals. So I've written the prescription, here's what I want back. And I think that fits into a lot of, wellness programs, certainly certain device data. I want your glucose 4 times a day, not maybe every time you measure it. And then there's the other piece that really does need to be met, which is the bring your own device. And health systems, as well as EMR vendors and other vendors, need to be able to accommodate these scenarios, because I think patients, clinicians, and health systems are going to want a mix. I'll make a few notes here that, some of the challenges we encountered were around iPhone, and that not all patients use an iPhone. You could have predicted that, but this pilot was a pilot. And then limitations around devices, which we could anticipate that we would need to have flexibility ultimately for patients to have whatever device they want to use. This took a lot of time. So this is a few excerpts from the consent, but I highlighted a few of the main things that had us stuck in a lot of meetings and talking through. And honestly, I think our leadership was just very pragmatic about this. And I'm not sure that all health systems have had the same perspective. So think about blood glucose and blood pressure a little bit more than a fitness tracker in this scenario. What do I do with information that comes to me at 2 in the morning? Is it actionable, and does the patient understand that I am not looking at their information 24/7? And so this had to be, at least for this pilot, it was part of the consent, and it was made very clear to patients that the way we structured this is actually they brought the data with them, and it was part of their visit. But you want to enable people to send you information. We just need to manage expectations around when and who is going to look at it. And then, does it flow into the legal medical record? What do we allow into the record? And those were all things that we had to think through. And again, in the context of a pilot, it was a little bit easier because it was a small number of people. And then, of course, a disclaimer around, we cannot speak to the accuracy of the device that you're using. And we're just viewing the information with you and trying to augment our care delivery. I'll mention this here, and then I think it'll come up as a little more obvious as we go on, is how do you view the information? So along with that point I just made about the medical record, do you push the data into your portal, your patient portal, and then or you push all of it or some of it into your medical record, or do you have providers go and pull it? Do they go view it in the portal, the patient's health record, or in just the application of the device or whatever kind of hub that you're using, so that the providers have that as part of their workflow? And those are all things that we've considered and others are considering as well. So here I'll say kind of where to partner. And what I mean by that is, do you go with the small companies that are innovating and are doing work and perhaps have very flexible apps and are in this space and ready to partner? Or do you stick with your kind of traditional, somewhere between either your vendor or who your vendor's partnering with? And I can say we've done both. We are doing both. We've done both. And one of the challenges of dealing with the small partners, I think there's a lot of benefit, honestly, in us supporting those small partners so that we can seed and try to support innovation. But we found that they don't have the deep pockets to have the liability coverage that would be required by a health system. So for us to partner with them, they needed to hold a certain amount of insurance, and many of them don't and can't. And that actually became a point of challenge and something that had to be worked through. You wouldn't want that to be a stopping point, I think. And along that, in that same thread would be the integration considerations and the real life fact that the smaller partners, it's sometimes hard to get the kind of integration that you want to support a clinical workflow, for example, potentially going into your medical record system, say. And I think Cerner has had great vision in some of these areas. I'm going to give you a couple of things, but they, one of the original discussions we had with them around glucometry, for example, I use this as just a point of what kinds of services are they bringing to market. Well, we said, we would like to measure glucose. We want to let people submit their glucose data. And it was interesting, though, to see that actually what the place that Cerner was going with this was, it was kind of a bundle. And so you had your device, so it was a particular device. And already that sort of, we didn't like that, because we like our patients to be able to choose what they want, right? We don't want them to have to use a particular device. But there was a particular device. And again, we understand in a pilot or an initial work, though, we are flexible. So we do that. They had their analytics, the smart cloud. So in this case, they had sort of the ability to analyze the data and chew on the data and put out the preformed results as they had deemed important. And then this was something that I just think was interesting. We didn't realize until we got into this space that this part of the package was sort of care management, care coordination. So there were diabetes educators in this case. Maybe in another case, it's sort of a wellness program that's linked in. And And as a health system, you may or may not want that. Maybe you want to own that yourself, or maybe you do want to outsource that. And so this is available. And I think for some people, this would work. For us, we're an academic medical center. We like to do it ourselves. So we want to do our own analytics, and we want to have our own diabetes educators. And so those were just some of the things that we thought about as we went through this, of the types of models and what's developing out in the marketplace. So the build, a lot of text, but this is just a fragment of some of the considerations that we had. As I referenced earlier, so where, from the clinician and the patient perspective, what's the end game in terms of where do you want to see the information? Of course, there's the what information, but where do I even want to see it? And that then dictates, well, what interfaces do I need to put in place? And as I said earlier, is it that the provider goes and views? Is it need to flow in? When we did flow some data in, and then even though we engaged providers and we said it's going to go here, and there's so much, for those of you who are clinicians, there's already so much frustration around the amount of information and how it looks, that this is a very important, is not shoving more data and putting it in places where we just can't find it in the midst of a lot of other data that we're having trouble finding. Get to that point about data in a moment. But so do you go and then pull it? And is it an easy enough interface that maybe providers could just go into some web portal and look at the information? And perhaps that's one of the ways you consider this. And we've gone through this quite a bit, which is when, who, how are results verified? Do they need to be verified? I think for fitness information, fitness data, I think it's probably not, it won't be as pressing. However, if you started to use that information to say if grandma got up in the morning and we're doing monitoring of elderly and we're looking at how they're moving around, then it might be. And so do you require an accept to, say, pull it into the chart, which is what we do with a lot of things. And we had lots of discussion, heated and interesting discussion on this, and some of us came to the point of saying, we put a lot of things in the chart, and a lot of things that I can't say that everybody has looked over and given so much due diligence and such. So we, I think, had appropriate flexibility to say that we would allow some things in because there would be a trail to say that it was patient-generated, and that we had consented the patients and said, we may or may not look at your information right away, and it will be part of your visit. And then we talked about the prescription piece, and there are folks who measure things very frequently, and back to the point about data kind of overload, you might want to say, we only need this many results per day. We will then get summary data analytics, which we'll talk about in a moment. But we don't want every measurement. We don't want that because it's actually going to be very hard for the provider to manage and deal with. The latency issue, ultimately, I think you want whatever works for the patient and the clinician. But we initially actually got around some challenges by saying, you're going to come with your data first pass. Because we actually, at the beginning, we didn't necessarily have a new workflow to support who's going to look over your data when you're not here, but we have a visit, so it's part of your visit initially. But in a future state, when we're doing what we are all working towards, and I can tell you Emory's working very hard on this and making great strides around population health management, you're responsible for people whether they're in your buildings or not. And so you have teams and structures in place that you are looking at these people almost like a command center, right? And you're looking at how's Mrs. Smith doing and all of her subjective and objective information. That is part of the vision, and part of it is so people don't have to drive down on Clifton campus and come in the traffic for visits that really could be handled asynchronously. But you've got to have the right staffing and teams, et cetera, in place to do that. and you have to transition, and you have to figure out kind of a transition strategy to get there. And then you can imagine a lot of time appropriately spent on the appropriate training for patients and providers, from the devices to the data flow, all of this, lots of training necessary. And selection, in particular for a pilot, you do need to select people carefully. So you'll forgive me this next slide, but I have to do this in my last few talks. And you'll understand in a moment why Nicolas Cage is up here. But these are his movies over the last many years, and he's done a lot of movies. If anyone has ever followed Nicolas Cage, he's in a lot of movies. And if you've seen this, I love this slide. There's a Bloomberg version of this, but it is, you can throw some data together and come to some conclusions. Turns out that Nicolas's movies track well with drowning. And as you all know, data doesn't equal knowledge, and at the end of the day, it's what do we do with it to make it meaningful? And this is a lot of the tension that providers have around how we manage patient-generated data. We are so excited and enthusiastic about this, I can tell you, and I'm right at the front of that. But we also listen to what are the current workflows and how do we make sure providers are doing everything that they need and want to do to bring value to patients. And so that's where I come to talking about the analytics. And I think so for an academic center, every discussion we've had has been, we want all the granular data. We are an academic medical center, we're a research institution, we want everything. We want that certainly from a research perspective. We're gonna want that. And some folks may or may not want to share that because some of their step calculations are proprietary. They've got logic behind how they come to their interpretations. But the sort of middleman, the intermediary, is something that we probably have shied away from a little bit. Now, however, there is some value in at least getting our feet started and having some meaningful interpretation of the data. Steps in particular, I would say. And Felipe has done a lot of work and thought in this area around, okay, maybe it's not just steps, but it's intensity of movement. It's how often people get up. It's some characteristics of the way they move. And for a post-operative patient, for example, you want to look at some other pieces of it. So making sure that we can get our hands on that is important for us to make good use of it. But we don't even get out of the gate without some summary data. And I'll say, even with that pilot that I described to you, and you would think that I would say glucose may be a little easier in terms of the data than some other things, although you want the metadata, you want what they eat, their calories, their carbohydrate intake. It was too much already for some of the endocrinologists. It was a lot of information, and they did want some summary. And so that helped us to plan out the next stage, which we are getting a little bit more summary data. What about flagging of abnormal values, some parameters and business rules around what's okay and not, and just the visual cues around it, forget about alerts, et cetera, but just knowing what is clinically relevant and I need to do something with. But if we want to do more sophisticated analysis, are we going to be able to export the data into something else? And are we going to be able to get into the database and use the information, which is one of our early questions and considerations. And then sort of the other big consideration, I referenced this earlier, but it is a real tension and consideration. It's sort of this evolution that health systems are going through as they become more responsible for population, as we shift our care models, is how do we have appropriate staffing and teams in place? So who's going to look at the information? Because just saying we now have this, but we don't have a workflow, a person, or whatever, to do something with it is probably not going to be successful. And so this is one of the early questions that providers will always ask, and clinical informaticists and will put out on the table, and figuring out that migration strategy is very important, because otherwise it does present itself as more data to look at, and perhaps not time for other things that are already stretched. So I put this little, if it plays, it stays, because that is somewhat where some of us are in medicine right now in terms of IT, is there's a lot of innovation, there's wonderful things that we're doing, and then there's just a lot of things that we also are figuring out, even how we work and use our EMR, and so we're in this middle ground of wanting to innovate and making sure we can accommodate innovation, and making sure we also can take care of the providers and the patients who are already being served by what we've already got in place.